We are listening from our speakers on these four pillars. My job is to establish the intravenous iron, the poor candidate, where and how it stands in the management of heart failure. So, iron deficiency is very common, highly prevalent, and it causes recurrent hospitalization and mortality. About 50% of patients of heart failure have got some form of iron deficiency. And it is not restricted to India, where the prevalence is very high. It is also prevalent in Europe and US, not less than 50%. In a study from Rajasthan, it was found that about 78% of the population of heart failure suffers from iron deficiency, of which 50%, about 50% have absolute or iron deficiency, and the other 25% have relative or functional iron deficiency. Then this functional iron deficiency is very important in the causation of anemia in heart failure, because heart failure is a low chronic inflammatory state, and there is the role of the inflammatory markers, that interleukin 6, interferon, gamma interferon, and that causes the release of hepcidin from hepatic sinusoidal cells, which blocks the receptor, and ferroproteins are not released or available for release from the abdominal surface of the intestine, as well as from the macrophage system for mobilization to circulation. So, prevalence is very high across the European country, across chronic heart failure as well as acute decompensated heart failure. Causes of iron deficiency in heart failure is simple: reduced intake because of low appetite and other causes of mucosa, increased loss, and there is reduced mobilization due to the factors of hepcidin block. That impact is in the level of the cardiomyocyte, and the mitochondrial respiration is hampered, and ultimately that leads to relaxation, contraction, all the effects are affected. Restoration leads to replacement, leads to improvement in the functioning. In the whole, the mitochondrial respiration and effect on cardiomyocyte leads to cardiomegaly, cardiac hypertrophy, systolic dysfunction, diastolic dysfunction, and hemorrhage. So that leads ultimately to exercise capacity reduction, quality of life is reduced, mortality is increased, recurrent hospitalization is increased. It is not that anemia is to be there. Iron deficiency is the most important determinant. As you see that when the iron deficiency starts, there is reduction in the function before the appearance of anemia in the middle part. And iron deficiency remains the independent predictor of mortality in anemic patient and non-anemic patient. If there is anemia plus iron deficiency, mortality is definitely high. But if there is no anemia but iron deficiency, the mortality is still higher than without iron deficiency anemia. So what can we do? Can we go for oral iron depletion? That has been turned out by iron out heart failure randomized clinical trial, which has shown that this has no benefit. After 16 weeks, there is no functional benefit. Why? Because the rate of oral iron absorption is slow, and that cannot overcome the hepcidin block. Increased iron, intravenous iron, intercellular iron, and that production of increased number of ferroprotein, and that overcomes the hepcidin block. Now, what is there in the iron? It is started in 1947 journey. Till 2009, we have got the right iron, IV iron. The unique moiety for the each compound of IV iron now used is carbohydrate cell surrounding the iron, core iron, elemental iron, which reduces the immunogenicity and increases the strength of stabilization. There are different forms of iron, IV iron, that is the ferric carboxymaltose, ferric isomaltose, ferric dedisomaltose, and ferroxytol. Now, Swedish heart failure registry has shown that hardly 25% of patients of heart failure undergo testing for iron deficiency, of which only 1 in 5 gets the IV iron. So iron deficiency is common and it's a neglected burden in heart failure management. So what do the guidelines say? If you get a patient of heart failure, you should monitor the ferritin first. If the ferritin is below 100, it is a candidate. If it is above 100 to below 299, but transferrin saturation is below 20%, then it is a candidate. And recommendation level is high, and it has to be used by ESC in 2021 to improve the quality of life, recurrent hospitalization. If the ejection fraction is below 45%, and in the discharged patient or acutely admitted patient at discharge, it should be given if the ejection fraction is below 50%. ACCHA on 2022 recommendation in patient with heart failure, reduced ejection fraction and iron deficiency with or without anemia, intravenous iron replacement is reasonable to improve functional status and quality of life. 2A recommendation. So where is the problem? Problem is the lack of awareness within ourselves. Why? Because heart failure symptoms and ID symptoms, that is iron deficiency symptoms, often
The permission was for 14,000 square feet. They have
fatigue, breathlessness and exercise intolerance is there in both the condition, overlapping.
whereas
So how do screen? You just screen the patient periodically. Suspected iron deficiency, heart failure, acute heart failure after before hospitalized discharge or after hospital discharge. Check iron deficiency status by those tests like ferritin and transferrin saturation as the condition may be. Check anemia status, whether it is below 13 or more than below 12 for in case of female, and exclude other causes of anemia as per the clinical status. If there is iron deficiency, then you may think of managing it as per the ejection function with symptomatic heart failure or hospitalized acute heart failure. If the hemoglobin is more than 15, don't go for IV iron. Dosing is very simple. If it is below 35 kg, all cases, irrespective of the hemoglobin level, you never exceed 500 milligram. I am saying about ferric carboxymaltose because we have a maximum experience with this molecule. But other iron preparations are there. If it is 35 to 70, then according to hemoglobin level, you have to adjust. Mostly 1,000 milligram is required. But if the hemoglobin level is below 10, you may go for 1,500. If it is more than 14, but less than 15, you can go for 500. Above that, you may have add 500 milligram in places but not in case of those patients of more than 40. Heart failure hospitalization, if you treat the patient and there is FCM requirement or IV iron requirement in every step after at discharge or after discharge. There are different iron of which ferromoxytol, ferric carboxymaltose, ferric isomaltose and dedisomaltose are now in use. This is confirmed by the different styles like fair HF, confirm HF, effect HF in case of ferric isomaltose, carboxymaltose. And it is also acute heart failure situation, it is good. And the problem is with the eyes are useless when the mind is blind. So summary, iron deficiency is even without anemia is very common. There is low adherence to guideline and intravenous iron therapy leads to improvement in functioning at least and reduces hospitalization. Thank you.